So, welcome to the Kanski lecture series, and it is the orbit part 5. And in this part, we are going to discuss about the non neoplastic vascular abnormalities. And in this part, we are going to discuss the cavernous sinus thrombosis and carotid cavernous fistula. So, basically, the carotid sinus thrombosis mean that a cavernous sinus is a portion in the intracranial cavity through which the lots of nerves and blood supply passes through. So whenever there is a thrombus formation in this area, it will causes the obstruction of the flow, and it can even cause the ophthalmoplegia. It can cause the proptosis, it can cause nerve palsies, and even if untreated it may lead to death. So, cavernous sinus thrombosis, this refer to the clotting within a cavernous sinus, usually resulting from the infection such as sinusitis, orbital and preseptal cellitis or otitis. So, there is a clotting of the cavernous sinus. There is a high mortality rate, 20% treated and up to 100% untreated die. Features are the rapid onset and may include severe headache, malaise, nausea, vomiting, unilateral or often bilateral proptosis, chemosis, congestion of the facial, conjunctival, and retinal veins. Reduced vision and signs resulting from the compromised function of the third to sixth cranial nerve, which runs through the cavernous sinus. Diagnosis is with imaging, especially MRI and MRI venography. Systemic investigation for infection is also performed, including lumbar puncture. Treatment consists of the intravenous antibiotics and sometimes surgical drainage. So you can make the diagnosis through MRI, and treatment is with the antibiotics because these are basically the cause which risk factor which causes the um, cavernous sinus thrombosis, like sinusitis, orbital cellitis, and if still not improving, we can give this surgical drainage. So, carotid cavernous fistula, very simple, is that there is a fistula formation. Fistula is basically an abnormal connection between the two bodies. So you know that a carotid artery passes through the cavernous sinus, and whenever there is a connection between them and there is an opening between them, this is called the carotid cavernous fistula. Now there are two types. One is a direct fistula and one second is an indirect. The direct one is basically the fistula in which the carotid artery is directly having a connection in the cavernous sinus, but in case of indirect, it is through the meningeal branches. Introduction. A carotid cavernous fistula involves the development of an atriovenous fistula between the carotid artery and the venous cavernous sinus, and with the rise in the venous pressure in the sinus and structure draining to it. Ocular manifestation occur because of the venous and arterial stasis around the eyes and orbit, increased epicycleral venous pressure, and a decrease in arterial blood flow to the cranial nerves within the cavernous sinus. Carotid cavernous fistulas are classified into direct and indirect forms. One of the very important type is that there will be the history of trauma in a case of a direct fistula. So, direct fistula are high flow shunt in which the carotid artery blood passes directly into the cavernous sinus through a defect in the wall of an intracavernous portion of the internal carotid artery as a result of trauma. 75%, including surgery, spontaneous rupture of an intracavernous carotid aneurysm or an atherosclerotic artery. The later, frequently in the middle-aged hypertensive women, spontaneous fistula usually have the lower flow. So basically, the direct fistula is like this is a carotid artery that is passing through the cavernous sinus, and there is an opening or connection which is causing the connection between the carotid artery and cavernous sinus. Most of the time, it is usually associated with trauma, but sometimes the surgery it can occur spontaneous rupture of a carotid aneurysm and atherosclerotic artery. And these are the high flow shunts. In an indirect fistula, dural shunt, the intracavernous portion of the internal carotid artery remain intact. Arterial blood flows through the meningeal branches of the external or the internal carotid artery indirect into the cavernous sinus, and the clinical features are subtler than in a direct fistula, such that the condition may be overlooked. Spontaneous rupture of an atherosclerotic artery or of a congenital malformation is the usual cause and may be precipitated by the minor trauma or straining. Connective tissue and collagen vascular disorders can be associated. So, in a case of indirect fistula, basically there are meningeal branches which causes the connection between the carotid artery and the cavernous sinus, and due to this it is usually subtler. And one thing is that usually occur in a case of a it is a congenital malformation. So diagnosis of the symptoms are direct is presentation may be days or weeks after head injury with the classic triad of the pulsatile proptosis, conjunctival chemosis, and a whooshing noise in the head. So the classic triad is that the process will be the pulsatile, and there will be the conjunctival chemosis, and there will be the whooshing noise in the head. Whereas the symptoms in the indirect is the gradual onset of redness of one or both eyes is the typical presentation caused by a conjunctival vascular engorgement. So then what is the sign? So you know that there is a during in the cavernous sinus there are cranial nerves that are passing through the it v1 v2 uh, trigeminal nerve 5 3 4 and 6 um, and also there is a carotid artery passing through it. So whenever there is a connection and it is causing a stasis of the blood in this cavernous sinus, it will cause the palsy of all these nerve supply, as well as because the arterial drainage are not adequate, it can cause the CRVO as well, and it will cause the increased episcleral venous pressure. It can cause proptosis as well. So direct signs are immediate visual loss may be due to ocular or optic nerve damage at the time of head trauma. So it can be due to whenever there is an immediate damage, it can be due to the head trauma that is associated with it. Delayed visual loss may occur as a result of exposure keratopathy. Why? Because of the proptosis, secondary glaucoma, central retinal vein occlusion, anterior segment ischemia, ischemic optic neuropathy. So there will be do not have an enough drainage. There can be ischemia because there is no blood supply, and there can be ischemic optic neuropathy. Signs are usually unilateral to the fistula but may be bilateral or even contralateral because of the midline connection between the two cavernous sinus. There will be the marked epibulbar vascular dilatation. So you will see the conjunctiva will, the more apparent sign will be that there will be the proptosis of the eye, there can be the eyelid swelling, there can be conjunctival congestion. So marked epibulbar vascular dilatation, chemosis, commonly hemorrhagic, particularly in early stages. Pulsatile proptosis associated with brew and thrill, both of which can be abolished by the ipsilateral carotid compression in the neck. So one of the very important sign is a pulsatile proptosis and a bruit. And how can you abolish it? Basically, if you compress the carotid artery, the bruit will be abolished. Increased IOP due to the elevated episcleral venous pressure and orbital congestion, and sometimes angle closure glaucoma. Because of the increased episcleral venous pressure, there will be the increased IOP, and it will can lead to the uh, uh, glaucoma, and sometimes there can be the angle closure glaucoma as well. Anterior segment ischemia characterized by corneal epithelial edema, aqueous cell and flare, and in severe cases iris atrophy, cataract, and rubeous's iritis. Ptosis occur due to the third nerve involvement. Now we are seeing that all the nerves are getting involvement. So ptosis will be due to the third nerve involvement. Of Ophthalmoplegia 60 to 70% due to the ocular motor nerve damage from the initial trauma, and intracavernous aneurysm of the fistula itself. The sixth cranial nerve is the most frequently affected because of the free floating location within the cavernous sinus. Third and the fourth nerves, situated in the lateral wall of the sinus, are less frequently involved. So, most commonly involved nerve is sixth cranial nerve. Engorgement and swelling of the extraocular muscle may also contribute to the defective ocular motility. Fundus examination may show optic disc swelling, venous dilatation, and intraretinal hemorrhage from the venous stasis and impaired retinal blood flow. Vitreous hemorrhage is rare. So, these are the signs of the CRVO, which will be present in the case of direct fistula. So, you know that in a case of CRVO, there can be optic disc swelling, there can be the venous dilatation, there can be intraretinal hemorrhage, and they can due to the venous stenosis and the impaired retinal blood flow. Vitreous hemorrhage is rare. Whereas in the case of signs in the direct is that there will be the mild epibulbar venous dilatation with a direct fistula. There will be the exaggerated ocular pulsation, which is readily detected on a slit lamp applanation tonometry. So, how will you know that there is a pulsation? Basically, you place the tonometer in the eye and you can see the pulsation of a tonometer. It will show. So, it is a how you check the pulsation with the slit lamp applanation tonometry. The presence of a corkscrew epibulbar vessel is a common subtler later sign. These are not pathognomic and can be found in normal eye. Raised IOP often bilateral but higher on the side of the fistula. Proptosis and bruit are mild if present. So all of the things are usually milder in case of an indirect fistula. And remember this is due to congenital or developmental cause. Ophthalmoplegia caused by the sixth cranial nerve palsy or swelling of the extraocular muscle is in marked cases. Fundus may be normal or manifest moderate to venous dilatation with a later tortuosity, as with the corkscrew conjunctival vessels, that is not pathognomic. So we can see this figure. So you can see that this is a direct case and this is an indirect case, because the sign is quite subtler in this case, but in this case it is very obvious sign. So carotid cavernous fistula A is showing the marked epibulbar vascular dilatation in established direct fistula. B is showing hemorrhagic emesis in an acute direct fistula. C is showing mild epibulbar vascular dilatation in a indirect fistula and corkscrew conjunctival vessel. So remember that this can also be present in a case of a normal eyes as well. So what the investigation can you perform? CT and MRI. CT and MRI may demonstrate the prominence of the superior ophthalmic vein, very important, and a diffuse enlargement of the extraocular muscle. Though these may only be visible with a direct fistula. Orbital Doppler imaging may show abnormal flow pattern, particularly in superior orbital vein. Definitive diagnosis may involve selective catheter, digital subtraction angiography, especially in milder dural fistula. CT and MRI angiography can be useful. So there is a procedure, digital subtraction angiography, which is basically the catheter is passing through the femoral vein and then to the eye. So uh, these are now less commonly performed. Now we do the CT and MRI basically to detect the superior ophthalmic vein. So we can see figure 6.4.23, and you can see here the prominent superior ophthalmic vein, and this is the enlargement of the extraocular muscle in this right eye. So CT in a direct carotid cavernous fistula A is showing the axial CT imaging showing enlargement of the right superior ophthalmic vein, and B is showing the coronal view showing enlargement of the extraocular muscles on the right. And so how will you treat the cases? Ocular complication may require specific measure in addition to the treatment of the fistula itself. Neurological subspecialist opinion may be sought at an early stage even if the features are mild, as some fistula pattern, for example, cortical venous drainage, carry a high risk of stroke. So you have to sort the neurological uh, s- uh, opinion in a case of a fistula. So, what happened in a direct fistula? Most carotid cavernous fistulas are not life threatening. The organ at major risk is eye. Surgery is indicated if the spontaneous closure does not occur. A post traumatic fistula is much likely to close on its own than a spontaneous fistula because of the higher blood flow. So if the fistula is due to the trauma, it is unlikely that it is going to close on its own. So you have to treat it. Treatment is likely to consist of the transarterial approach to repair the artery, for example, coil or um, other, or occlude the involved sinus, for example, coil, balloon, or other. Craniotomy for arterial repair is occasionally needed. So there is a procedure to repair the artery. It is a transarterial approach, and you place basically the balloon or coil in the artery, so it will distort the connection between the carotid and the cavernous. So we can see figure 4.24. So it is a coil embolization of a direct carotid cavernous fistula. A is showing early arterial phase catheter angiogram showing filling of the cavernous sinus and the superior ophthalmic vein. B is following deposition of the coil in the cavernous sinus. The fistula is closed and there is no retrograde flow um, in the superior ophthalmic vein. So you can see here that basically in the early arterial phase, the this is a cavernous sinus is filling, as well as there is a superior ophthalmic vein is also filling. So after placing the coil, there the fistula is closed and there is no retrograde flow in the superior ophthalmic vein. Indirect, if required, treatment usually involve transvenous occlusion of the involved sinus. Spontaneous closure or occluding thrombosis sometimes occur. Intermittent carotid compression under specialist supervision has been reported to increase the likelihood that this will take place. So basically, you can occlude it in the indirect as well, the involved sinus, but it is usually through the transvenous occlusion. Now we are going to discuss about some cystic lesion. In this case, we are going to study about the dacryops and dermoid cyst and mucocele and encephalocele. So basically the cystic lesion dacryops is basically the cyst of the lacrimal gland. A dacryops is a frequently bilateral cyst of the lacrimal gland that is thought to develop from the dilated obstructed duct. A round cyst lesion protrude into the superior fornix from the palpebral lobe of the gland and may present with inflammation. The possibility of a malignant tumor should always be considered. Treatment to involve excision or marsupialization with histopathological analysis. So we can see figure 4.25. You can see that there is a cyst that is extending from the lacrimal gland, and you can see on the eversion of the lid, and the treatment is basically you just excise it off with and sending the specimen for the histopathological purpose to rule out any cancer. Next is a dermoid cyst. So dermoid cyst is basically a developmental or embryological disorder, and what happened is that there is a normal tissue that is present in an abnormal location, and the most common location is the supratemporal. So a dermoid cyst or an orbital dermoid cyst is a choristoma. So there is um, a term choristoma and hamartoma. So choristoma is basically a term in which the normal tissue is present in an abnormal location, whereas a hamartoma is the abnormal proliferation of a normal cell. So, dermoid cyst is a choristoma. It is a mass of histologically normal tissue in an abnormal location derived from the displacement of ectoderm into to a subcutaneous location along the embryonic line of closure. Dermoid are lined by the keratized stratified squamous epithelium like skin, have fibrous wall and contain dermal appendages such as sweat gland, sebaceous gland, and hair follicle. Epidermoid cysts do not contain adnexal structure. So basically, this is the difference between the dermoid cyst and the epidermoid cyst. Basically, the dermoids are lined by the skin, and in between it contains different sweat glands, sebaceous gland, and hair follicles. Dermoid may be superficial or deep, located anterior or posterior to the orbital septum, respectively. Epipulmar dermoid and dermolipomas are related lesions. Diagnosis: dermoid cysts are one of the most frequently encountered orbital tumors in children. Symptoms: so there is a superficial dermoid and a deep dermoid. A superficial orbital dermoid cyst present in infancy with a painless nodule, most commonly located in the supratemporal and occasionally in the supranasal part of the orbit. A deep dermoid cyst present in an adolescent or adult life with a gradually increasingly protruding eye or acutely with an inflamed orbit due to rupture. So, a superficial dermoid is basically present in the supratemporal area of the eye, but sometimes it occur in the supranasal part as well. And the deep is usually present in the adulthood when it usually rupture. Signs: superficial, a round, firm, round, smooth, non-tender mass, 1 to 2 centimeter in diameter, mobile under the skin but usually tethered to the adjacent periosteum. So very important that it has a bony adhesion as well. The posterior margin are easily palpable, denoting a lack of a deeper origin or extension. Deep will cause the proptosis, dystopia, or a mass lesion with an indistinct posterior margin. So basically, investigation, you have to perform the CT scan to rule out any other cause of pathology, and also for the bony tethering. So for the superficial imaging, show a well circumscribed heterogeneous cystic lesion because it contains different types of uh, material. Deep imaging shows a well circumscribed lesion. Some deep dermoid associated with bony defect may extend into the infratemporal fossa or intracranially. So treatment is small lesion may be observed, bearing in mind the possibility of rupture, particularly from trauma. The inflammation can be addressed with oral steroid. So if the dermoid is ruptured, you can give steroid to reduce the inflammation. So how will you treat the superficial dermoid and a deep dermoid? Superficial treatment is by excision in toto. In toto mean that you uh, excise the lesion without rupturing the dermoid itself, because if you rupture the dermoid, it can induce the inflammation in the surrounding tissue, and it can cause a severe inflammation afterward. So treatment is with the incision in toto, taking care not to rupture the lesion, since leaking of the keratin into the surrounding tissue typically result in severe granulomatous inflammation. Deep dermoid excision is toto is advisable because deep dermoid enlarge and may leak into adjacent tissue, inducing inflammation, often followed by fibrosis. If incompletely excised, dermoid may recur with the persistent low-grade inflammation. So this is showing the orbital dermoid cyst. A is showing the superficial cyst, right eye. Left is showing left deep cyst causing mild dystopia. 4.27 is showing orbital dermoid cyst imaging. A is showing axial CT imaging, showing a well circumscribed heterogeneous superficial lesion. So this is a heterogeneous superficial lesion. And B is showing the deep dermoid, showing a well circumscribed cystic lesion, and there is a bony remodeling as well. So this is how we treat it. superficial. So A is showing us a superficial orbital dermoid cyst, and B is showing the excised specimen, and we have excised it with in toto. So next is a mucocele, sinus mucocele. A mucocele, US spelling mucocele, develop when a drainage of a normal paranasal sinuses secretion is obstructed due to a infection, allergy, trauma, tumor, or congenital narrowing. A slowly expanding cystic accumulation of a mucoid secretion and epithelial debris develop and gradually erodes the bony wall of the sinus, causing symptoms of encroachment upon the surrounding tissue. Orbital invasion occur usually from the frontal or ethmoidal mucocele, but rarely for those arising from the maxillary sinus. Presentation in adulthood life is with the proptosis or diplopia or epiphora. Pain is uncommon unless since secondary infection develop. CT scan show a soft tissue mass with the thinning or erosion of the bony wall of the sinus. Treatment involves complete excision. So, what is basically a mucocele? So, you know that this is eye, and we have a frontal sinus above the eyes. We have on the side there are ethmoid sinus, and below the eye is the maxillary sinus. So mucocele is basically when the drainage of the paranasal sinuses are blocked, so there is an accumulated secretion. When there is an accumulated secretion, it will cause a mass formation. What will cause it? Can cause destruction of the bony wall and even invade the orbit. So most of the time it's the frontal and the ethmoid sinus that invade the orbit. So when it invade the orbit, it will cause the proptosis and dystopia uh, of the eye, and the treatment of it is basically the surgical excision. Encephalocele. An encephalocele, US spelling encephalocele, is formed by the herniation of an intracranial contents through a congenital defect of the base of the skull and can be located at the front or back of the head. A meningocoele contains only dura, while the meningoencephalocele also contain the brain tissue. Presentation is usually during infancy. Interior orbital encephalocele involve the supromedial part of the orbit and displays the globe forward and laterally, whereas posterior orbital encephalocele frequently associated with neurofibromatosis type 1 displays the globe forward and downward. The displacement increase on straining or crying and may be reduced by manual pressure. Pulsating proptosis may occur due to the communication with the subarachnoid space, but the communication, because the communication is not muscular, there is neither thrill or nor a bruit. CT scan show the bony defect responsible for the herniation. The differential diagnosis of the interior encephalocele includes other causes of medial canthal swelling such as dermoid cyst and amniotocele, and of posterior encephalocele include other orbital lesions that present during the early life such as capillary hemangioma, juvenile xanthogranuloma, teratoma, and microphthalmos with the cyst. So basically the major important point in a case of encephalocele is basically it is a developmental disorder. What happen is whenever there is a defect in a intracranial cavity and there is a herniation of a brain tissue, it is basically the encephalocele. And what will is called, it will cause the pulsatile proptosis without bruit and thrill because of the communication of the CSF and the orbit. And what happen is basically there can be two types of mm, encephalocele, anterior and posterior. So basically the posterior is usually related with NF1, and it both of them causes proptosis, but the anterior one causes the proptosis forwards and lateral, whereas posterior causes the forward and downward. So basically these are the important points of the encephalocele, and major differential diagnosis is dermoid cyst and posterior amniotocele. So that's it for the orbit Part 5. See you in the next lecture.